Welcome everyone to today's webinar. We're going to give folks who are coming in now just another moment or two to join, and we'll be starting shortly. Well, welcome everyone to this webinar, The Intersection of Medical Travel, Insurance, and Transitions of Care, the latest in a series of programs focusing on transitions of care and specifically Project RED, Re-Engineered Discharge, and the scientifically derived and validated principles of Project RED, which can reduce the risks and costly errors of ineffective transitions of care. With Dr. Brian Jack, who created Project RED, Elizabeth Nziemba and I have developed Project RED Solutions, a consulting firm focused on implementing Project RED in healthcare systems around the world. We're convinced that improving transitions of care results in better patient outcomes, happier staff, plus more effective and sustainable systems. Project RED principles improve safety and care quality, increasing efficiency and reduce the risk through adhering to best-of-class standards. Project RED Solutions delivers training, implementation consulting, and measurement for better transitions of care. To learn about Project RED Solutions, access webinars, and other resources, please visit our website, projectredsolutions.com, or contact any of us after this webinar. In our last webinar, we looked at the case management principles and international transitions of care in the international medical travel or medical tourism markets. Today, we are delighted to have Torkel Leakey, who, and I know I mispronounced his name, so Torkel will straighten me out, who'll cover how the private medical insurance providers view medical travel and how the principles of Project RED mesh with what insurance providers are looking for. With the growing penetration and acceptance of private medical insurance, it's becoming progressively more important to know the principles and how to apply them. This is what Torkel will review. Torkel has over 2 decades of experience shaping the landscape of the medical assistance industry. Torkel has pioneered global collaborations and cutting-edge solutions between and among payers and providers. His expertise includes travel insurance, international private medical insurance, and medical assistance, where he focuses on optimizing services for both consumers and business partners. I've learned and continue to learn a lot from Torkel, and I know our audience will as well. Before I turn the virtual microphone to Torkel, I want to encourage our audience, remind our audience that you can add your comments and questions and observations into the chat box in your screens. But if you really want to have your questions answered, I would encourage you to put them into the Q&A, which will be monitored during the program. So thank you to the audience for signing up and participating. Thank you, Torkel. The digital stage is yours.
Thank you, Irving. Thank you for inviting me to this. This is actually the first time I do a webinar, so bear with me if I have some technical issues here. But I'm thrilled to be here as well and be allowed to share some of my views. I think after your extensive presentation of me, I don't need to go too much into details here. This is just to show some of my background from the medical assistance, some of the companies I worked with or had assignments for. And as you say, I'm always focusing on creating the right solutions for the companies I'm involved with. I have really an eye for this triple win for the insurer payer, the provider, and the member or the insured. My background is what some refer to as the Nordic model of medical assistance, and that is where we have a 360-degree on a case, including getting access to treatment, the quality, but of course also the costs. So let me go straight into some of the things we'll cover in this session. And first, we'll talk a little bit about what types of insurances could be involved in medical tourism. You will hear that I use a term, the payers, and that is in combination for the insurer, the TPA, the assistance company. It's those who pay the medical providers. It's the perspective, how insurance companies or the payers typically look at it. We'll also take in a point that I see can give a negative influence on this if you overlook it, and it's quite an important one. And then there'll be some recommendation towards the end. I also need to put up this disclaimer that I'm independent. I advise companies, so I'm not speaking here on behalf of anyone in particular. I'm speaking of everyone and not anyone. And I will try not just to have a US focus, but a global focus, because that is how I work. I'm based in Copenhagen in Denmark, but I worked globally with these topics. So what is the idea of a medical insurance? Insurance in general, you often have this love-hate relationship and the fine print. But the fine print is where you go to see what is actually covered. Then on the negative side, you'll hear, well, it's all about decline, decline, decline. But that's not what I see with the companies I worked. It's about keeping a promise. Insurance is, we promise we'll cover your cost if this happens. And the part I'm involved in typically is keeping that promise. It's when someone needs to use their insurance for a treatment. UCR is a frequently used term. That's usual, customary, and reasonable. Some ask, is it reasonable? Well, it's, in lack of any other way, the best way to illustrate what is covered, because you cannot put a fixed amount on a certain kind of treatment, because it depends whether you are in Hong Kong, in India, in Germany, or in the US. So UCR is really a good way to express it. Are insurance companies reasonable? Yes, they are. But of course, there are areas where they become strict. Anything that is looking like a red flag could be signs of fraud, signs of treatment for something that is not covered. Then an insurer, the payer, will become strict, because this is a business. It's not a charity. It's keeping a promise. And how strict varies a little bit from market to market. Also, if there's some areas where you see excessive treatment, overbilling or waste, that is also the focus of the payers, because if you can control your costs, you also keep the premium down. And that's one of the principles as well. Let's keep premium down so it's a good product and people want to buy it. So let's look a little bit about IPMI, International Private Medical Insurance. It's in many ways different from just a normal health insurance that you have in the country you live. And that's the first I that makes the difference, because a traditional local private medical insurance, for the insurer, the members will go to known facilities, maybe in a smaller geographic area, but with the international part, all of a sudden it can be all over. But you add in factors such as different cultures, different norms, different protocols. They're not the same all over the world. Multiple currencies as well. So it becomes more complex. Also in IPMI, there can be exclusions. Policies can be medically underwritten, so my policy can be very different from Irving's or anyone else, even though it's more or less the same product we have bought. And then allow me to bring in travel insurance, which is my original starting point, because there are some overlaps, some similarities, because it is also about getting a treatment in a location that is not where you're from. You are maybe an expatriate or you are traveling, so you are a little bit in unfamiliar territory. But whereas the IPMI covers also planned treatment, a travel insurance will never do that. Travel insurance is for accidents, for emergencies, for something acute worsening. So never any planned treatment. But travel insurance typically covers your repatriation costs, and they can be quite expensive if you need that. An IPMI policy typically does not cover that. So I highlight this again because I'll touch back on this in a few slides' time. You could raise the question, do insurers benefit from medical tourism? And maybe many people will say, no, they don't. I say yes. Actually, I say it's a need. It's not just something that is nice. And I'll give you 4 examples here. The first one is from an IPMI insurer. It's a case they presented at a conference last year, so I allow myself to use just the extracts from that. But this was an expatriate living in Hong Kong that needed an elective treatment. Hong Kong is a good place to live. It's a good place to have treatment, but it's also one of the most expensive places in Asia. So what this insurer did was they, when the member reached out asking for coverage for this treatment, they said, how about if we organize, you can go to Thailand, we'll cover the flights, we'll add in this and this and this and this. He accepted. Bottom line for the insurer was it cost them $9,000 less. So this is, in my opinion, medical tourism because he went to another place than where he was residing for treatment. I have seen several companies in LATAM who offer their members to go for treatment in the US if they want or need more advanced treatment. But everyone knows that the US is the most expensive place to go. Sorry, Irving. And what I've seen over the past years is that some say, we'll waive the deductible, we waive the co-payment. If you just go to Spain, it's fine, go to the most expensive facility in Spain, it's still cheaper. So they're happy to do that. Whereas that European insurer will say, oh, that facility in Spain is a little bit expensive, it's the most expensive, could you go somewhere else? But here it's better than the US. So that is also a medical tourism. And I think also people from that region would prefer sometimes to go to Spain, or the Brazilian goes to Portugal because you are in your same language, your known language. This is an example from a colleague who was in China. They expected a child and they realized how expensive it would be to have the child in China. And any IPMI insurer is so scared if the insured wants to go to Hong Kong. Beautiful places. I've been to some of them. Beautiful view if you're on the peak, but it comes with a price tag. And these colleagues of mine, they went to Bangkok and it was 1/6 of the price. That's the difference you see in such an area. Could also be you need to go to another place because you need that kind of treatment that is not available. Could also be in China, could also be in Latam, but you can also be an expatriate in an area where it's far to the really good facility, and then you again need to have medical tourism for a treatment, and your IPMI insurer pays for it. So that is how I look at medical tourism. It's more frequently used. It's not just for someone who wants to go, it's and pay themselves. It is also covered by the insurance. Let's bring some color into this. This is a world map that I've developed over many years, trying to take a lot of different factors and just illustrate in one slide how the world can be seen. It is a simplified illustration. So you can always debate whether this country should be this color or that color. It's being adjusted from time to time, but the overall idea is the darker blue, the more safe you can be in terms of treatment and cost. It's not going to ruin you to have an expensive treatment. On the other end of the scale, on the red end, you have to consider if you really want to have that treatment in this location, because you may not have the skills for that. And then you have all sorts in between. I think I'm working with 8-9 colors here. You can work with fewer or less. But what I do notice is what I call the cost containment range. Of course, the US is there because you have to pay attention to cost containment because it can be very expensive. But in the same category, I put countries like Spain, Portugal, Greece, Turkey, Thailand, Japan, Korea, and some Hong Kong is and Singapore is there as well, but and also some dots around Moscow and St. Petersburg, because it can be frightfully expensive compared to other facilities nearby. Also, some of the green countries are in this range. All of South America, you have some really good facilities, but you also have some really expensive ones, or some overcharging ones. Today we're not naming any names, that's not the point of it, but it's to say there are some areas where you really have to be careful when you're the insurer, whether you're the IPMI insurer or the travel insurer. An interesting thing is also that those countries that are in this range very often are the medical tourism countries. People go there maybe because of the very high level of treatment. We can take the US as the example of that, or you go because it's cheaper. We have Spain as the example I just had. So yeah, that it's illustrating the world in one slide from this perspective. We are getting towards the real topic, and that is the discharge information, because that is what Project Red is about. And do insurers focus on this? Well, we have the two kinds of insurances. So let's start with the travel insurance. It's very integrated into the process when you are a medical assistance company, because you always have to evaluate, is there need for an evacuation or repatriation? So it starts from the very beginning. And every 2-3 days during this patient is admitted, there's typically a follow-up between the assistance company and the treating physician. And that is because the mindset is the case does not end at discharge, because if there's going to be a repatriation, it's part of the cost as well. The companies, they have learned the lessons that it's better to be proactive, because you can avoid aborted missions, delays or readmissions, or even readmissions in your home country if you have done your follow-up and everything correctly. Also, when you have a medical repatriation, you will have a doctor or nurse coming to the patient on site to escort him or her home. And they always check up all the medical notes. They ask what discharge medication, what should we do, because they're medical professional. So it's in really good hands. And also, if they see any issues, they typically report back to the network management team. That is where I started my work, and that could be the kind of feedback I got from a medical escort, that we should have a chat with this provider. But for the IPMI, I do not see the same types of protocols. There's a lot of focus on the pre-authorization, because policies are typically more complicated. I see that organizations spend more time to evaluate the guarantee of payment or verification of benefits, look into pre-existing conditions and so on. But once the guarantee of payment, the verification of benefits is placed, sometimes there is no more follow-up until the claims start coming in, with the mindset that the patient is in good hands with a treating physician. We assume they do the best they can, period. There might be some who look a little bit on statistics on different things, could be readmissions and maybe rate flag it, but I don't see it as a big thing. So that's two very different ways of operating with an insurance that covers treatment in a foreign country. Contracting, insurance companies, or it could be payers here, what are they focusing on when they're contracting? Is it legal? Is this facility actually holding the proper license? If you knew what especially assistance companies and travel insurance see of examples in, I'm going to mention some countries, in Greece, in Turkey, in Mexico, of facilities who have inpatients without the proper license, you will be amazed. It's not a topic for today, but it is an important thing. Also, payers want less hassle for the lowest cost. If you narrow your network too much, members insured might be unhappy. If you have too much steerage, they might be unhappy. But you still need to control your costs, of course. But I have it down in this priority actually, because that's how I have experienced. I've done the work myself and how others are doing it. But also a thing as the collaboration. If you have a partner, if you have a provider that takes a lot of admin time, it costs you on the administration, and then you're not so happy to work with them. So someone who will follow your protocols, who easily to communicate with, will have your priority. Some may ask, where's quality? It's down here. Still considering that license has to be in place, and that is then licensed according to local regulations. They are typically different, whether you're in the US or in India or in China. But this is typically what you look at, very simplified. And then I'll share a little bit of experience how it is contracting in tourist areas, because tourist areas is also areas for medical tourism. I contracted myself, and I have this example from Turkey. And that is, I always looked at when I went into a facility, is it busy here? Why? Because if it's busy, if it's crowded with local patients, it's a good sign for me. It means local insurance is supporting it. It means local self-payers are supporting it. It has a good reputation. People come back. The way we verified it was together with our local partner. in this part of Turkey, the governor's office, they made statistics on the number of hospital beds, deaths, birth, surgeries, etc., for each inpatient facility that was licensed. The worst example I've seen was one hospital with an occupancy rate of 8 to 13% over the years. I can see Irving is saying, wow, even though it's muted. And what it means is they had the building, the facility, all the equipment there, but they only had 1/10 of the capacity they were built for. So of course they had to try and squeeze as much money out of each and every patient as possible. Of course, they were interested in having as much medical tourism as possible. This was when it was just starting up 15, 20 years ago. But when I came with a doctor, they were not always so happy about what they saw. So rule of thumb, go for busy places. There's a reason why it's busy. I reached out to some of my contacts, not naming any names here, but this is based on input from typically chief medical officers or medical directors in large insurers or assistance companies. It also includes some of the BUCAs, so we have the US perspective as well. And I asked, do they focus on discharge information when it's IPMI? They do not see very many hospitals that focus on this, even though everyone or a lot of people know that studies exist that show the value, not just in costs, but also in well-being for the patient. Some may do it as a part of the case management. They know it's important, especially in a cross-border situation, because there could be the language to consider. If all the medical notes, if all the information is in Spanish, but you're not Spanish speaker yourself, I don't speak Spanish. So if I'm admitted in a Spanish speaking hospital, I would need some help one way or the other. Maybe they're looking a little bit at readmissions if they occur a lot, but they say, well, we're not really tracking this. Also, because the way they contract, if they contract on case rates or DRG rates, then most often it's built into the contract that if there's any readmission while on site, it's included. Then it's not going to make the payer pay more to the facility. It's the headache of the facility. It makes sense. But also what they do is they do agree that there is a need for more focus on the transition from care to home. So, last thing is, as a person who has also contracted with facility, if I have to choose from, one has, let's say, an accreditation they read, I would go with them first and not with the other one. We'll get back to that. But first, let's go flying. Aeromedicine. Why is that important? We are talking about discharge information here. But I mentioned earlier that in medical assistance and travel insurance, there is an eye for following the patient, not just until discharge, but all the way. And sometimes all the way means you have to get home this way. So for those who do not know, the picture in the top is showing a stretcher installed on a commercial aircraft. You can see these outside of the US, no US carrier offices, but big companies such as Air France, KLM, Lufthansa, Emirates, Etihad, Qatar, they do offer it also on their long haul flights. So you have a stretcher, you put down 3 rows, and you have also a seat for the medical escort. That has to be a medical escort or 2 when you do this kind. You have a curtain to pull around for privacy. That is the least costly compared to the air ambulance. That's what you see in the below, which is basically a flying ICU. You do want patients to be stable when you move them around. but these are typical ways of how you can do it. The reason I bring it in is our bodies react differently when we are 40,000 feet above the ground, even in a pressurized cabin. And doctors have many different topics they're trained in, but not everyone is trained in aeromedicine, and that can be quite important because ready for discharge is not the same as fit to fly. If you are transporting on a commercial stretcher, airlines require MEDIF, that is medical information. It's a standardized form, it's a IATA form that everyone who's involved know this has to be filled out, submitted to the airline for their approval, because they don't want to take anyone on board that is not safe if they have to make diversions or emergency landings. And this is what medical assistance companies, ambulance companies, they know. But are you aware that if you have bariatric surgery, maybe you should wait 10 to 14 days before you get in a pressurized cabin, because you risk that you have complications from this. This is what I have it from a bariatric surgeon specialist who also works for assistance company. He's used to making the authorization for patients to go home. So he knows, of course. I actually have some colleagues who wrote a book on this. So it is a special area. But individuals may not know it. Or the guy, sorry, the doctor who only does bariatric surgery, he may not know either. So yeah, we will discharge you tomorrow. You're good to go. You may not be good to go. Personal example. The joke in SOS when I was there was even us in network management, we end up in hospital sometimes. We try it out on our own body. I was hospitalized one evening with severe back pains, and I needed quite a lot of morphine to be able to just sleep a little bit. I was hospitalized for 2 days, and yay, I could go home. And then the doctor from the assistance company said, we'll put you in a hotel for 2 days. Because if we put you on a flight right now and you are in heavy turbulence, it will all come back. Do you want that? No, I don't. So that is why discharge or ready for discharge is not the same as fit to fly. And you need to be aware of this. Because all your precautions you have done for your treatment, you can lose the effect or you can make it worse if you go high flying too soon. And now we'll switch topic. Today I'm going to a good restaurant for dinner. No, there's a point. Many are familiar with what is this guy doing. You know that there are 3-star restaurants that is really creme de la creme. I'm not going to one of those. But you also have Bib Gourmand, which is good food for good money. It's really reasonable. Why do I bring it up? Because we're going to talk about accreditation, because being in the Red Book is for many seen as a good accreditation. It's quality stamp. And especially facilities and in payers are familiar with JCI and TEMAS. Not going into the details of those, many are also familiar with ISO on the corporate level. ISO also means you define your quality yourself. And I was in another industry before this. I was working with a company doing uniforms for the military here in Denmark. And the people in this said jokingly, well, if we specify it's okay to have a hole in fabric every 2 meters, and it's written in our document, it's actually okay, and it will pass inspection. So you have to be careful about what you set as your criteria. But the one I want to highlight here is Urami. Urami started a little more than 30 years ago by medical air rescue experts. And today, it's an accreditation that no serious air ambulance organization would be without. It is originating out of Europe, but I see it significant that, because again, sorry, Irving, you're on the other side of the pond normally. The US has a tendency of doing their own. You're not metric, you're using Fahrenheit and so, but for this one, there are as many URAMI certified air ambulance providers in the Americas as in Europe, because this is what the buyers of this, the payers, the assistance company, they know if you are going to do one of the most expensive things in medical assistance, having an ambulance, you want to be sure nothing is wrong. And if you have a URAM accreditation, everything has been vetted. Protocols, aircraft, equipment, staff, and everything. And actually it has led to, here's a small commercial for GAMTI, which is the Global Assistance and Medical Transport Institute. Some of the same people behind, but this time they have also invited me into their advisory board. And it has just been launched. If you follow it on LinkedIn, otherwise follow it because it's really interesting. This is a way to certify, to give accreditation to the people working in medical assistance, which will be really, really good for the industry. And when I first heard of Project Red, I think this was one of my first comparisons to Irving and to Elizabeth, saying, so it's kind of the same. Why is it? Because it's also started by the experts within the industry. It's not a government thing. It's the industry itself that says, we believe we have a need for this. And the Project Red does cover an area that is important, and there's nothing like it right now. I mentioned earlier that as a professional buyer, it would be easier for me if I know this facility has a Project Red accreditation, then I have less risk of readmission. So, any facilities out there now, you have to pay attention, because this is a little bit about what you can do. Support this, because do not expect the payers or the insurers will take the initiative. They will not. They will welcome it, and they will also find it very useful. So I brought up this about URAMI to draw this parallel. Apply the same mindset. One of the points is the next door facility that you may think you're competing with is not your competitor. It's your colleague in the industry. Join forces with them, because your competitor is probably a facility located far away in another country. Because if I am here and I'm looking for treatment going medical tourism, I could choose between Thailand or Turkey or Spain or Mexico or the US, depending on what my coverage is for. So I'm not necessarily looking at one or two hospitals in the same area. Make sure you document that you have an enhanced quality. That's what people like me like to see. We want to see your statistics, that you have good control of this, that you have low readmission rates. And what you can hope for if you do this is it will be part of the payer selection criteria. Who makes it to our list of preferred providers? And that's where most facilities want to be. So, cost or investment, I guess the audience will already know what I think it is an investment. Dear providers, you have to take the initiative here, because it's about reducing the cost, reducing the errors and the waste, because that also improves your bottom line. Not just in hospital care, it's in any industry. Two examples. I said I was in fashion. My very first job, starting in 1989, I traveled to China and Hong Kong and other places. I did inspection of garments before shipment because no one wants defects to be shipped out to the stores because you cannot sell it or you cannot get full price. You don't want your brand to be ruined by this. That's why it paid off to do it. IKEA, I think all of us know about IKEA, and we associate it with being cheap. It is cheaper than others often, but it's also thoroughly tested. I think most of the things you have bought in IKEA, you will realize, oh, they actually last for a long time because IKEA does not want it to be returned. And if it happens, they have a quite generous policy for that. So I know this is bold, but is a readmitted patient a return? I would argue yes, because you don't want a patient to come back if you could have avoided it. Can you do that? Can you support this through a better discharge planning? That is what Irving and Elizabeth can talk about for a long time, because that is what it is about. Yes, it's about people's life, but it's also about doing it in a good way. Look at airlines. What do? Clear written protocols, training, and checklists. Book, what is Project Red about? Clear written protocols, training, and checklists. And we're not mentioning Boeing today. Or look at it the Japanese way, continuous improvements, not because someone says so, but because you just want to. That is what drives many organizations. We can always be a little bit better, and this is one of the ways. Thank you.
Thank you, Torkel. And if I can get control of the deck here,
I'll stop sharing.
thank you. So thank you, Thorkel. And I have I paid attention to what you were talking about, and I think that our audience probably garnered a lot of benefit from that. And indeed, one of the principles that you talk about is the need to have control over the quality. And the first issue here is, what are the controls? You mentioned the analogy between the retail space of product returns and the return of a patient to the hospital. Well, that environment gets significantly more complicated, much more expensive, and potentially life-threatening in the healthcare environment. So the principles behind re-engineered discharge, or Project Red, apply to virtually all transitions of care, but we focus on hospital readmissions. Hospital readmissions are an example of a problem that comes about either because the patient's clinical situation has changed, or because the treatment wasn't correct, or the post-operative, the post-treatment care plan wasn't correct. So we're going to focus on a few things. So there are two categories of these standards that have been proven to reduce post-hospital problems. First is to provide an after-hospital care plan that the patient understands. Torkel mentioned this, that there is a need to make sure that the patient, the consumer, the individual being discharged, and her support system or family, that they understand what's going on, that they understand what to look for. The second issue is medication reconciliation and education. What type of medicine are you taking? What type of medicine needs to be taken when you get home or wherever you're going? And what to look for interactions, for problems with the medicine, and what not to take. So many patients, especially with chronic conditions, when they're leaving the hospital, they're going home and they have a cabinet full, a medicine cabinet full of medication. And they often don't know that much of this should not be taken, much of this should be discharged. There needs to be a follow-up plan for outstanding labs and tests. People who are sick enough to be in the hospital in the first place are sick enough to need care after they leave the hospital. And those individuals need labs, need tests, need x-rays, need scans. Setting those up and arranging them before the individual leaves the hospital or the clinic is a standard of care. It should absolutely be done. And that creates the issue in the international market about how are these coordinated across borders. And I really want to thank Thorkel for bringing up the issue of how other hospitals in your marketplace area may not be your direct competitors, and that some of them may have a connection in a distant market, in a distant location where you can get support for setting up these labs and the tests. Another principle is to arrange follow-up appointments that the patient can keep. Doesn't make any sense to schedule that follow-up MRI if on a Friday, if the patient doesn't have any way to get to the scanning center, the MRI or the hospital on that Friday. So make sure that the appointments can be kept. Arranging for post-discharge services and equipment. Does the patient need a wheelchair? Does the patient need a walker? Does the patient need oxygen? Does the patient need wound care supplies? All of these things, all of these factors are understood by the clinic and the hospital care team that are discharging the patient, but the patient isn't going to take responsibility for doing this. It needs to be all arranged by the discharging hospital. And sometimes language or what's available in one place is different from what's available in another place. So these international or cross-border differences need to be taken into account and handled by the hospital care plan, hospital case management team. The discharge plan for the patient needs to be rationalized with any national or international guidelines. That's a very specific issue around chronic care, for example, for heart conditions. Does the discharge plan or the after hospital care plan comply with the national guidelines in the location where the patient is returning to, as well as international guidelines, especially as Turkel mentioned, the fit to fly rules and the guidelines from IATA around the MEDIF files. And then send the discharge summary, the after hospital care plan, to the primary care provider within 2 days. Many hospitals don't do this. Many clinics fail to communicate with the patient's primary care team in the patient's home location. Meaningful telephone reinforcement, at least within 2 days after discharge. Again, sometimes language is the barrier, but often the issue here that we discover is the assumptions. For a private medical insurance provider, the assumption is that the care is being done by a competent provider. The doctor and the hospital are properly licensed. Well, they're just going to take care of that. Well, no, it isn't unless the hospital and the doctor have these guidelines, these re-engineered discharge guidelines as standards of care. There are important behavioral-based, interpersonal, and educational principles as well. The first is to assess the patient understanding of what her diagnosis is, what her post-operative or post-treatment care plan is, what she needs to look out for when she gets home in a day or 2 days or 3 days. What should the wound look like? And actually show pictures of what the wound should look like and what the wound should not look like. What should it feel like? What should it not feel like? And confirm that the patient understands that. This is often referred to as teach back, and it's an active learning, adult learning principle that I was just talking to somebody today. We'll probably create a video on what should be practiced to confirm that patients understand what it is they should be looking for. In all of this, of course, language assistance is critical. We need to provide education to the patients about their diagnoses, and we need to involve the family caregiver in discharge planning. Explain common problems and what to do if the problem arises. So the example of what your wound should look like is a good example. The wound may be itchy. It may feel as though it's pulling, but so long as it stays clean, and what does that look like? It's not red. It's not hot to the touch. It doesn't feel tender, then it's probably fine. But if it looks like this, you should absolutely call, and who to call. So this list and the prior list, the interpersonal as well as the systems-based standards of care, are on our website, Project Red Solutions, in a toolkit that's free, and you can download it there. So why this focus? I thought that Torkel mentioned this and did a good job. If you're sick enough to be in the hospital, you're going to need care afterward. The international cross-border markets for medical travelers, sometimes referred to as medical tourism, sometimes health tourism, medical travel. The focus has not been on what happens afterwards. There have been some very high-profile problems in this regard, with people becoming desperately sick and dying after treatment in one location because they returned to another location and didn't have proper after hospital care. And that's what we're attempting to address with Project Red Solutions. Hospital readmissions or retreatments may be the result of clinical change. That is to say, the condition changes. A patient gets a heart condition after having hip surgery. That's not out of the ordinary. That's not very strange, but too often it's the result of incomplete or incomplete initial treatment of poor quality. It's also sometimes the result of the individual who doesn't take care of him or herself and isn't told what to do and what not to do. And even if she is, they don't do it. Or the problems that result in these readmissions or the reemergence of problems could be the procedural or process errors that we've already talked about. In any event, these are unnecessary, inappropriate readmissions. They put the patient at risk, they put the provider at risk, and they waste resources. They cost a lot unnecessarily. These problems occur because of communications problems. And in our implementation of these Project Red solutions in hospitals, we find a pattern of problems with regards to communications. And their evidence-based research has shown that individuals who leave the hospital don't have their discharge summary available. And after a few weeks, they absolutely don't have access to the information that's critical to their post-operative care, to their post-treatment care, even a few weeks afterward. And when they do have these discharge summaries or after hospital care plans, these summaries are lacking critical information. The course of treatment in the hospital, list of discharge medications, completed test results, pending test results, and follow-up plans. That direct communications with post-hospital providers happen in only 3 to 20%. 1 out of 5 patients being discharged have adequate communication between the discharging hospital or clinic and their treatment provider. And these are all, this data was collected from within country, within the same country, within one country. These data are probably far worse, most likely far worse across borders when the individual is located in one country, goes to another country for treatment, and then returns to her country. And the challenges are simple: miscommunication, lack of information, inadequate follow-up and care, fragmentation of care, and resource limitations. Our primary objectives at Project Red Solutions, and the primary objectives for the purpose of this presentation and all of the work we do, is to improve the discharge process, to reduce hospital readmissions and unnecessary retreatments, and to enhance patient outcomes, to actually improve the outcomes that patients have from their treatments, and especially from their cross-border treatment. So what I'd like to do here is stop and see about questions. So do we have questions?
We did have a question about whether or not we'll be sharing this recording, and so I wanted to just say yes, we will be. Next week we will send out an email follow-up.
Thank you, Emily.
Yes. One question, how do the Project Red standards differ from current practice?
Well, if Torkel talked about this, that there really isn't much in the way of current standard practice. In your work with insurance providers, Torkel, do you see after hospital care being in any way standardized, or do you see the kinds of things we were talking about, providers arranging after hospital care?
I don't know how everyone works, so there could be some who do this, but it's not the typical pattern that I see. It is more a reactive handling. Here is someone who wants to use the insurance to cover for a certain treatment. Then we have a look at that. We say yes or no. It's the parallel to the travel assistance is more the mindset. It does not end necessarily as at discharge. You have to consider, how does this patient, this traveler, get home to her home country or continue the travel, because otherwise there'll just be more cost. But I don't see anything standardized. No.
This is, I thought your distinction about the focus of the travel assistance company on the aftercare versus the focus of the private medical insurance providers on the pre-care, the evaluation ahead of time. I thought that was really revealing. And so I would say, and this is my experience as well, having operated a self-insured plan for a large national employer in the United States, I can absolutely say that we focused on utilization review. We didn't focus on aftercare review. So thank you. Are there other questions there, Emily?
But Irving, if I just may add,
Please.
I believe a lot of this is on the shoulders of the facilities, the doctors, because they are the ones who are closest to the patient. That is where the initiative should come from, because they should have the KPIs on how many patients are returning here. It should be no one where it could have been avoided. Yes, you gave the example, sometimes there can be side effects, but that is where they should do it, and that is what they should probably spend more energy on showing to those paying for it, because then we, as the people contracting with them, we will take that into consideration, make it a selection criteria.
Well said. Well said. Well, I think there are quite a few more questions, and I think we are out of time. But for those of you who are listening and who are keen to hear the questions, we will make a transcription of the questions, and Torkel and I will attempt to answer the questions as best we can understand them and send those transcripts along with the recording. So I want to keep to the keep to the hour. If there's another question we can squeeze in, let's do that, Emily.
Sure. Is there a single Project Red document that summarizes the recommendations for effective discharge planning?
Excellent. Yes, there is, and it's on the Project Red Solutions website. It's cleverly projectredsolutions.com. And there is the toolkit that's there that has the standards of care that I reviewed in the slides listed out, and a lot of other information as well. And that's free, and you can download that and use that within your institutions. If there's something there that you don't understand or you feel we can be of assistance, I hope you'll be in touch. So let me just say, let me again thank Torkel for an excellent presentation. Thanks to everyone for attending, and look for an email from us with the link to the recording of this program and others. We encourage you to share these resources with your colleagues whom you think may benefit. And be on the lookout for more programs in 2024. We're expanding the topic of care transitions to the international stage, examining how transitions of care are managed in other countries and between countries. Be on the lookout for these alerts in your email. Our next program is on Wednesday, 17 April, when we'll tackle the technological interface between medical insurance and healthcare providers in cross-border medical services, better known as medical tourism. It should be a terrific program. And please visit projectredsolutions.com to access today's program, our other resources, and to learn more about how Project Red Solutions can help you take advantage of Project Red principles through training, implementation consulting, and the measurement for better transitions of care. Thank you, and have a terrific rest of your day.